Welcome, everybody, to another Lunch and Learn workshop. Today's theme is treatment planning, always a fun topic and one that is so necessary for what we do in our field. I see some familiar faces. Hello, I'm Dr. Jana Bonvini, and I am joined today by my amazing, fantastic, wonderful, incredible colleagues, Drs. Tiffany Sutherland and Dr. Marina Bunch. If you haven't had them yet for class, hopefully you will. You'll be blessed with that in your time here at UC. But one thing that we do know is that treatment planning can often be a hard concept and a hard skill for students to master. How many of you have written a treatment plan before? Just a show of hands. I know, Kate, I know you have because you were in one of my classes, and Lena, Rachel. Okay, yeah. I know a lot of you have, but some it might be sort of this black box, like how do I know what is a goal versus an intervention versus an objective? And then others, it's a skill that comes maybe a little bit more naturally. A lot of times when people have a teaching background, they definitely understand treatment planning a little bit better because they're had to write lesson plans from the beginning of their training. So today we are going to walk through different elements of treatment planning. Here's our lovely objectives. We're going to go ahead and talk about the importance of it, how to use assessment to develop our treatment plans, how your theoretical approach really does tie into it. I see Kim and Kate in here and a couple others that I had last semester in my grief class, and I probably spend more time than most students like saying it needs to align, right? If you are, using sort of existential theory as your framework, I don't want to see a completely CBT theoretical or treatment plan because it's just not going to align. So I'll talk a little bit more about that. And then Dr. Sutherland's going to go through the essentials of the treatment plan and how it all fits together. And then Dr. Bunch is going to talk about special considerations and wrap us up. So we'll have some time for Q&A at the end too. So if you have questions, we will definitely get to those as well. So what is a treatment plan, right? Let's go all the way to a basic, right? A treatment plan is really a collaborative effort to engage the client in not only defining their goals of treatment, but also keeping us focused. I'm sure some of you have had the experience where you go into a session and you have sort of a plan of what you're going to do, and the client comes in and says, "Did you see what was on the Kardashians last night?" And then next thing you know, it's like a rabbit hole. You're like, wait a minute. Our treatment plans help guide what we're trying to do in our session. And so it's really important to have it as a focusing document where you're going to pick up from last time. It can really help us, provide additional support throughout the treatment. It can help whenever we have to do a referral. We can say, this is what we've worked on. Here's our progress, here's where we are, and here's where we plan to go. Or if you need to hand off to a different clinician for whatever reason, maybe a higher level of care or a different level of care because maybe they're leaving your facility and going somewhere else. It's a way to transfer that knowledge and to transfer those actions. So there's a lot of reasons why we do treatment plans. These are just some of them, but these are the ones that I think are most common. So assessment. I know several of you probably have already had the assessment courses, but really we need to make sure that we are getting an adequate history whenever we're discussing someone's treatment plan, because if we don't ask, if we don't do an appropriate assessment, an appropriate biopsychosocial, if we're not using self-report measures, such as maybe you're using the Beck depression or the Beck anxiety, or maybe if you're working with kiddos, maybe you're using the Conners or something else like that. Or maybe if you work with really high-risk clients that I often did, I use the Columbia rating scale quite a bit. So it just depends on what you're using. So oftentimes you're using these self-report measures, and we're also looking at level of care and level of risk. I don't know if any of you work in sort of the substance use field where you're always having to assess level of care, because your assessed level of care determines what type of program and what type of treatment that particular client's getting. So for example, if someone's level of care is that is an intensive outpatient program, right? You're looking at somebody who's going to be in treatment probably somewhere between 3 and 9 hours a week versus somebody who might be in like a partial hospitalization program where you're looking at upwards to 20 plus hours per week. Or if somebody is outpatient, you're looking at about 1 to 2 hours per week. So oftentimes with some treatment, you want to assess the correct level of care so you're properly matching your client with the care that they need, right? You're also going to want to look at risk. So for example, if you have a high risk client, you might not want to see them just once a week outpatient. right? You might want to see them more often. You might want to refer to a higher level of care or other programming to keep them engaged in services, depending on that level of risk. So all of these things are really important to prior to figuring out your treatment plan. Right. So you're doing this assessment. You probably will come up with a diagnosis, and then from there, treatment plan. So there's an order to the way that we do things. So what does our treatment plan do, right? It does a lot. The first thing it does is identify a problem. I know Dr. Sutherland probably had several of you in her diagnosis class, and one thing that I love that she does in her class is she starts the problem with the client's own words. I mean, how powerful is it to have somebody listen to you so attentively and use your own words as a statement of the problem? Like, I'm having a really hard time grieving the loss of my mom, right? You know, or client misses her mom so much she can barely breathe. Like using the client's own words as part of that formulation, I think is really powerful and really meaningful. And then it's like, what are we going to do about it? Right? What is that goal? What does that look like? Treatment goals can form the bedrock of our treatment plans, right? They define success. This is what it means to know that we're done. And this can be short term, this can be medium term, this can be long term, depending on your client and what you're working through. But then what you're doing with the objectives, that's what you're using to reach these goals. And I think sometimes when people are just starting out in the field, this can sometimes get conflated, right? They're like, the objective is to not have any more symptoms of depression. That's my objective. And my goal is, that I'm going to get enough sleep. It's like, no, we have to really be mindful of the way that we're goal setting, doing the short, medium, and long term, depending on, again, our client. And then what we're going to do, what are those objectives in reaching those goals? And then the interventions is like, what is the method or what is that thing that we're going to do to get there? Right. So we're going to scaffold this. Dr. Sutherland's going to talk about this in detail in each of hers. But we really want to make sure that this all connects. Right. So oftentimes we're thinking about interventions, we're looking at the techniques and the approaches that will be used. So for example, I tend to be very DBT in my approach. And a common intervention for people who use DBT is behavioral chaining. So if I have one of my teen clients who self-harms, I have them always do a behavior chain, right? So maybe I'm having them talk about how they felt when they got home from school, and then they got that snap from their friend, and it made them feel this kind of way. And then they thought this, and then they felt this, and then they did this. And so I had them go ahead and chain all the way to what happened and then what happened in the aftermath. That's a very common sort of DBT intervention. And I do that quite a bit. And then what we do is we figure out where we could break the chain in the future so that becomes part of their skill set, their toolkit moving forward. So depending on sort of your theoretical approach, oftentimes a lot of those interventions will align with that. Okay. Just a little PSA, the treatment plan should always be collaborative, right? It's really important to sit down with your client and talk through the way that you're going to approach their treatment. I mean, think about it this way. If you went to the doctor, okay, just stay with me here for a second, and the doctor prescribed a treatment plan and medication without bothering to tell you what was wrong or what your lab said, or even considering your perspective, you would feel some kind of way about that. You would feel this person doesn't get me. This person thinks that they are here and I am here, even though I'm the one who's paying them, right? Right. There is just this feeling of disconnect. And we also know that collaborative approaches in that theoretical or that therapeutic alliance is one of the most important factors in someone getting better and someone improving. Right. So coming alongside the person, talking through what things mean, not assuming that they understand what you're saying when you say, I'm going to behavior chain, I'm using DBT, I'm using EMDR. Right. So, and I just for the record, like I've used EMDR and I've had some clients go, I don't want to do that. That seems kind of woo woo. I really don't want to hold tappers or have your finger going back and forth. No, thanks. If I have to, maybe I'll reconsider it. I don't really want to do that. Okay. Okay. I'm not going to say, but I think it'll help. Like, no. It needs to be collaborative for us to move forward together and for them to trust you that you have their best interests at heart. You're listening to them. You're taking into consideration what they want for their own treatment. And I think that's a really, really important piece that sometimes gets missed. I've worked in agencies before where almost everybody has the same treatment plan. I'm like, yeah, they all might have a substance use disorder, but that doesn't mean they all need the same thing. It doesn't mean that they have the same history of trauma or the same co-occurring disorder or they come from the same background. That doesn't mean they should all have the same treatment plan. But there are some places where there's cookie cutter treatment plans. But I just think even in places like that, it is really important to still get your client's point of view, what works for them, what doesn't, and how to sort of put your spin on what can be a very cookie cutter type of plan. All right, buckle up, y'all. So this is like my favorite part to talk about. And for those who have had me in class, you're like, yes, I know. So when we talk about what your theoretical orientation is, a lot of times I think people are like, this is just the theory I use. But oftentimes I liken it to this is how you see the change process happening. And for me, as a faculty member, I find it so cool to see so many different people in this program have their own views of how change happens. And for some people, it's purely aligned with one orientation. For other people, it's definitely an integrated approach, right? And that's kind of cool. And I love to take the same case study and see how various people use their positionality, use how they see change happen, and counsel that client, right? I've used the same two case studies for about a year now, and it's so cool to see how they're going to counsel little Jason viewing a Gestalt approach versus existential versus a person-centered play therapy versus a DBT, right? And it's just it's so fun for me. But what I also noticed though, with some folks, they have trouble taking that change process and converting that into a treatment plan. So there can be this disconnect. I've seen time and time again that students are like, I'm person centered. Maybe there's something else that they rely on too. And then I open up their treatment plan. And at this point, I am like loving their case conceptualization. I'm so excited. I get to the treatment plan and it's all CBT. And I'm like, did I miss something? And I scroll up, there's no CBT mentioned. I scroll back down and it's all CBT. Now, CBT is pretty straightforward in terms of treatment planning. And I know a lot of you are familiar with that because you get the Jongsma book and it's predominantly CBT with an evidence-based, which is amazing. But other theoretical approaches have great setups for goals and objectives and interventions too. So if someone's saying that they're existential and then I open that treatment plan and it's Gestalt, we should have a discussion about what's going on here. But I think sometimes people aren't really sure how to translate that. So just as an example, so let's say that I'm using CBT as my theoretical approach. So it might look like something like, talking to my client who's experiencing persistent negative thoughts and having trouble completing tasks. And so I'm going to use techniques that assume that the thoughts are causing the inability to complete the tasks, right? So treatment would be formulated to address those negative thoughts, right? So maybe it's because they have some thought distortions, maybe it's from some other reason, but really I'm focusing on that. Whereas for me doing DBT, perhaps they're coming to me because they have severe anxiety, right? If my client has trouble self-regulating their emotions enough to calm down, then I might use some different tools that are available to me in DBT. Maybe I'm using some distress tolerance skills. Maybe I'm using some self-soothing to just have better emotional control, right? So my treatment plan would then be oriented towards mindfulness and learning skills that would improve my client's experience, right? So there are just different ways that we can think about what our approach is and then carry that through the treatment. All right. Gonna hand it over to Dr. Sutherland. I'll be your Vanna. If I'm taking too long to change slides, just let me know.
Okay, then I'm going to be Pat. Hey, y'all. So first, we use a SMART format, and this is really nice when you're beginning to do treatment planning because it kind of gives you a guide on what specifics or what things you need to be aware of. So we always want to be specific. Treatment planning should not be broad. Something to keep in mind is it is collaborative, like Dr. Bonfini said. So our client has access to it. They can request to have a copy of their treatment plan so they can do these things in between seeing us and weekly sessions. So we need to really specify what it is the client and I have agreed on that they will be working towards for improvement. Measurable. Insurance companies, all of us are going to be dealing with them. They want to see, how are we tracking the progress? So how many times are we expecting or suggesting the client work on this? How many percent of the time? We need to have some type of quantifying measure to show that we are tracking if the client is improving or regressing. Achievable. We love clients who shoot for the stars. It happens all the time. I love it, but that is not achievable all of the time. So we really want to help our client just make it more realistic, more doable, because when the client shoots for the stars and they don't make it, then that just further regresses them, right? That's where they can get depressed or just shameful or just really embarrassed or just really negative on themselves. Relevant. The goal should make sense. So when it comes to being relevant, something to keep in mind is resources are great, support is great, but our treatment plan is for our client. So we really want to make sure the things that we are working on when it comes to objectives and interventions, it's solely for them. They're able to take full responsibility for what it is they want to change and work on. And then the last one is time related. Standard usually in our field is 90 days. When we're working on a specific goal or objective, and then we reassess and see if we need to keep it or if we can change it. But we need some type of time-related component to show that we are actively reassessing or checking in on their treatment. So the goal in general, this is really where we pull in what the client's words are, what they want to see differently or what they want to change. So it's the focus. It's really kind of like the umbrella for the treatment. So it's usually long term, like Dr. Bonfini said. Sometimes it could be in the middle, short term, but this is the intended outcome of treatment. What is going to be different for our client? Can you go to the next slide, Vanna? Thank you. So objectives, a lot of folks get the objectives and interventions confused. So when we're talking about objectives, this is client specific. This is what the client is going to be doing. So we have our goal. The objective should match that goal. So it's more short term. What is the client going to be doing to progress towards that goal? It should be actionable. The client coming to therapy is not an objective. We know that. That's why we're making the treatment plan. The client going to group, that's not an objective. Really what we're trying to do here is identify something that they can work on in the session, but also outside of the session. They should actively be working towards something and doing that work. So the objective should state specifically what they will be doing. This is also where we can add in that measurable component that we pulled from the SMART goal. So how many times will the client participate in whatever activity, or how many times will they work on whatever the objective is that we have identified? Next one, please. Thank you. Interventions, this is us. This is where we show our theoretical orientational modality. This is where we pull in our technique. So this should solely focus on what we will do to help support the client. So if we're CBT oriented, or I'm integrative, I like CBT, mindfulness-based, psychodynamic, all of that you will see in my interventions. It needs to match. So we have our umbrella like we talked about. We got the goal, we have the objective, and then the intervention should pretty much pull everything in together. And how can we support the client? What are we going to do to help get them towards that goal progression? Next one, please. Okay, so this is pulling everything in together. So this is a sample treatment plan of a client I was working with a couple years ago. I think they were about 10 or 11. So it's standard that you have a problem statement. Problem statement is also the client's words. Usually it's what they're doing, whatever the negative behavior, maladaptive behavior, or thought process or content is. So for this client, it was, I get mad quickly and I say mean things a lot. So my interpretation of that is the client is struggling with healthy social interactions and response negatively impacting his interpersonal functioning. This is always great when we compare the client statement with our interpretation of it. So the goal for this client, he said, I can do better with talking to my friends and not yelling. So the way we get the goal statement is we ask, like, if you're in therapy or if you want to do therapy, what do you want to be different? What do you want to work on? So if you can think about your life 60 days from now, how could it be different? And so that's where we can pull a statement. So from that, client will learn and implement effective social skills. So this is matching, right? Our problem statement, he says mean things, his interpersonal functioning is negative. So the goal matches because we're going to work on the social skills. So the first objective, it's really standard in the field that you have a goal, and then you're going to have 2 objectives. So our first objective is the client will incorporate and improve his social skills twice weekly for 90 days. This is client focused. He's going to improve his social skills and incorporate these skills twice weekly for 90 days. That's the measurable component. So this is clear what he's going to be working on. So when we get to the interventions, this is what I will do to help him learn these social skills. So I'm CBT oriented. So this is where my theoretical orientation comes in. So I'm going to use CBT to do activities, worksheets to help him learn a little bit psychoeducation. I'm also using CBT to actually role model in the session how to have effective communication skills and provide feedback in the moment. Something when it comes to treatment planning is, depending on if you're focused more on the cognitive piece or the behavioral piece, that really will determine how we're going to use our interventions. So a lot of times if we're trying to tackle certain behaviors, our approach is going to be behaviorally oriented. So the second objective for him is decreasing these maladaptive behaviors. So when he says mean things, he gets really frustrated. So his objective is to identify these behaviors and then decrease them once weekly for 90 days. What I will do with my interventions is still using CBT, but I'm going to help him process and identify how his thoughts can connect to these behaviors because there's something there. And then I'm also going to use a little bit of mindfulness-based techniques to help him relax and calm down and center him in those moments. So this is a pretty general but very good treatment plan that shows you how everything makes sense and how everything matches and goes together. That's how all your treatment plans should be. Very individualized, very clear, very clean cut. So if I'm not working with this client anymore, and for example, if Dr. Bunch or Dr. Bonfini pick up my treatment plan, they have an idea of what to do. It should be no confusion for us, the client, or the insurance companies when they look at what is the problem, what are you all doing to work towards goal progression, and how are you doing it? I am done, Vanna.
Okay, hi everybody. So, special considerations, kids and teens, right? Kids and teens are different than adults, so there's many special considerations that we need to think about when we're working with kids of all ages, from the very young ones to teens up to 18. So remember that a good treatment plan starts with a thorough assessment process. So for example, how do we assess a child ages 0 to 5? So it's important that we understand development. We know that the social and emotional well-being and the developmental trajectory of a young child are directly tied to the quality of the child's primary attachment relationships. Therefore, observing and assessing the parent-child relationships and overall quality of attachment is essential to our case conceptualization, and also guides our treatment planning process, right? So in that assessment process, we must also be thorough in our questions regarding prenatal history, developmental milestones. Again, all of these factors are going to help us better understand the problem. And then when we truly understand the problem and conceptualize it, that's how we know how to intervene, right? What our treatment is going to look like. When assessing teens, you're going to gather information from the parent and the teen. And what you'll find oftentimes is that the reports may be conflicting, right? Because parents will often bring a child or a teen to therapy because there are some challenges with behaviors. Of course, there's various issues why teens may present, but this is a common one. So we might find that there's conflicting kind of perspectives. So our job is always to balance what the parents' concerns are while still ensuring that we're giving the teen, understanding that that teen is our client, giving them the space to share their own point of view so we can hear that, hold that, and balance the two. So even with teens, we need to pay special attention to the quality of the parent-child relationship, the dynamics in the home environment. All of those things are important to our conceptualization and, again, how we intervene. Assessing overall development is also essential for our teen clients as well. So when we think about assessment for kids and teens, it's a combination of various things, and it takes a while. So combination of observation, right? Observation of that child, teen, the parent-child relationship, There's parent report, there's child report, there's assessment tools and screeners. For the younger kids, that's a niche, that's a special population, right? If you're working with an infant and early childhood mental health. So there's advanced trainings to help you learn how to assess attachment, overall quality of the parent-child relationship. In addition, there's various developmental screeners. So we need to know about development, right? We need to know enough to know when to screen and refer. So there's various developmental screeners out there that can aid you in determining if a referral is necessary, right? So that's part of your conceptualization, and that's part of how you intervene. Something really important to remember about kids and teens is that they come with parents. So when I got into this field, I always said, I want to work with kids. Kids come with parents. It's layered, right? So you're never just working with the child. So remember that children and teens, they don't exist in a vacuum. Caregivers are essential to the assessment and treatment process. We know that there's barriers to this sometimes, depending on the setting that you work in, right? So if you're working in a school, for instance, it can be harder to engage parents. If a child's in foster care, which we'll talk a little bit about, it can be harder to engage caregivers. But when possible, we should always make efforts to engage parents in that assessment process and that treatment process. All right, Ms. Vanna, next slide. So the treatment plan. So Dr. Bonfini talked about the importance of collaboration earlier in this presentation. So again, with kids and teens, collaboration continues to be very important. So we want to ensure that the child, even the young ones, of course, not if you have a 1 or 2 year old, that's going to look different, but the young ones, like a 4-year-old, we want to ensure that they understand why they're in treatment, what you guys are working on, what the goals are, right? So there's a way that we can do that that's developmentally appropriate so a young child can understand that. When working with kids and teens, there's various systems that they're involved in, right? So sometimes it is important if, for instance, if a child is struggling in school, that we collaborate, that we consult with teachers and school staff. So therefore, sometimes our goals and objectives, they may be related to the school environment and what's happening there. So we want to collaborate. There's also other systems that children and teens may be a part of, such as child welfare. So we need to always remember the context, right? So the child may be in foster care, a group home, a residential facility. So understanding the context of the child's environment is essential to a thorough and informed treatment plan, and also collaboration with those adults in that child's life. When you work with kids and teens, you may run into situations where there's parental separation and divorce cases. In those scenarios, we also should always try to engage both parents in the treatment planning process. So although one parent can consent to treatment, therapy will likely be more effective if we have both parents on board, right? If there's co-parenting happening, right? We want to make sure there's consistency between the two homes. So for that reason, and we can also minimize any potential problems that can occur if there's a lack of transparency with the other parent, right? So if mom brings the child to treatment, dad doesn't know about it, for example, dad doesn't agree, dad's not involved, dad complains, like there are scenarios like that can happen. So we can work on minimizing those potential problems by being transparent from the very beginning, letting the other parent know that the child's presenting to therapy, inviting them to be part of, the process, the treatment plan, viewing it, etc. Also, and I touched on this a little bit, but when we work with kids and teens, oftentimes a multidisciplinary perspective is essential, right? So I talked about that importance of thoroughly assessing the child's development and knowing when to refer to additional services. So that is something that's going to be included in your overall treatment plan and really the process, right, of collaborating with other professionals. So some examples may be the need to refer to a pediatrician or a developmental pediatrician, another kind of medical doctor, an occupational therapist, speech and language pathologist, maybe a psychiatrist for medication management, or a psychologist for neuropsychological testing, right? So there's, we need to think in terms of multidisciplinary approach when we work with kids and teens when necessary. And so the last piece of this, and I'm going to say that this for me is a pet peeve, and if you have taken, or if you do take my child and adolescent class, you'll hear me talk about this. But if there's caregivers, so like I said, there are barriers to bringing caregivers in to the treatment process. There's many times where caregivers are difficult to engage for different reasons, but when we can, we should. And a big pet peeve is, putting the onus just on a child. So if we have a 5-year-old that is having trouble with self-regulation, it wouldn't be developmentally informed to have a treatment plan that says, Johnny is going to learn these skills to self-regulate, blah, 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 right? Because if we understand children that age, we understand the importance of co-regulation, for example, right? So do not, when you have other adults involved that are willing to be a part of the treatment process, do not put the onus on the child in the treatment plan. Remember that kids don't exist in vacuums, so their well-being directly relates to the quality of their primary caregiving relationships and their environment. So incorporating the caregiver, goals for the caregiver, dyadic goals, so relational goals between the child and the parent, or sometimes family goals when we assess the problem to be relational, family-based, or associated with the environment is important. So like Dr. Bonfini talked about conceptualization. So if we conceptualize the problem to be a family dynamic issue or a parent-child relationship problem, then our goals, our objectives, and our interventions should reflect the conceptualization of the problem. And so you want that to be a clear thread, which I'll talk about a little bit in a moment. All right, Vanna, next slide, please. There's a lot on this slide, and you guys will be able to kind of look at this at some other time, and I won't go over everything on here, but these are just some examples of common areas that we might focus on in treatment when we work with kids and teens. There's of course others, but these are some. And I also wanted to include some examples of what some child-centered play therapy goals might look like in treatment, because sometimes those are challenging for clinicians to think about. And then some caregiver-focused goals. And some dyadic relational goals. Remember that these are the goals, right? And then off of these goals, you're going to have your measurable objectives and interventions that outline how you're going to meet these overarching goals. But these are just some examples. And like Dr. Bonfini said earlier, there are, in the past when I've supervised clinicians working with kids, there's been some struggles in developing like objectives that are measurable, right, for child-centered play therapy, for instance, or the parent-child relationship. But there are ways that we can do that. There are ways that we can write our objectives in a way that are measurable when we're working in child-centered play therapy or when we're doing dyadic work. So again, just some examples here for you of what those goals might look like. In a relational sense. So for instance, a child's caregiver might have trouble with emotional regulation and you assess that to be the problem and that's impacting the child. So we put a goal in there for the caregiver, right? They'll demonstrate the capacity to be emotionally attuned and empathize with the child, for example, or create emotional safety, right? Or we might have a dyadic goal that involves the relationship, right? So the caregiver will demonstrate the capacity to self-regulate and engage in co-regulation with the child. And the child will participate in co-regulation with the caregiver, developing a greater capacity to self-regulate, right? Because children learn regulation through co-regulation. All right, next slide, please. And then this last piece, so when we work with kids and teens, sometimes they may be involved in different systems. One of those, depending on where you work, right? You may work with kids in the foster care systems or kids that are in different kinds of custody arrangements like relative care, group homes, et cetera, right? So when kids are involved in different systems, it adds additional layers for us and different considerations for our work. So for kids in foster care or state care, like I said, relative care, group homes, residential facilities, et cetera, we need to ensure that the case manager, or so if the child is not in the custody of the parents, we need to understand who the custodian is, right? If it's state custody, it's oftentimes the case manager. So we need to ensure that the case manager or another appointed state custodian views and signs the treatment plan. So that's really important. So in addition, any other adult involved in the child's care and treatment should be involved in the treatment planning process. For example, a foster parent, biological parent who might be working towards reunification, the relative caregiver, group home parent, et cetera. So remember that kids and teens, they don't exist in vacuums. So we must consider the caregiving and the environmental context when determining our treatment plan goals and who should be involved in the treatment. So for example, if a child is in foster care, we should do our best to engage the foster parent in the treatment process. Some foster parents are going to be much more willing to do that than others, but I've had a lot of success engaging foster parents. In addition, if a biological parent is actively working towards reunification, for example, and is a safe person for the child, we should also engage the biological parent in the treatment process. The same holds true for a relative caregiver, like a grandmother, an aunt, an uncle, or another adult caring for the child. So remember, your treatment plan goals and objectives should reflect the involvement of the caregiver in the child's life. And lastly, so we should have a systems perspective, right? When conceptualizing kids and teens, we want to think about them in the context of their environments and how those environments may be impacting their mental health. So we should always consider, the smaller and larger systems. So certainly the home environment, the family system, school system, child welfare system. So we should have this wide lens. So sometimes part of our treatment process may involve directly advocating or supporting parental advocacy for the client's needs in the systems that they are involved in. So again, all of these things should be part of our larger case conceptualization, which is going to inform your treatment plan and then your overall approach. All right, next slide, please. So there's lots of important points to remember. These are a few, but some takeaways that we hope that you guys gain from this is that, why is a treatment plan important, right? Well, it's a roadmap. It guides your treatment process, right? So it tells you how your client is progressing through the treatment, if things need to be changed, et cetera. It's a roadmap to keep you and your client and your treatment on track. Assessment doesn't just happen in the beginning, right? So assessment is ongoing. It happens throughout the treatment process. So you are constantly assessing, like Dr. Sutherland said, treatment plans, typically you'll do a 3-month treatment plan and you're constantly assessing to see how is this client doing? How is the client progressing? Are they achieving your goals? Or is there something else as you've gotten to know this client that pops up as a presenting concern and something that needs attention? So ongoing assessment is key. It never ends. Collaboration, remember the importance of collaboration, right? So your client should be part of the treatment planning process. Sometimes we do need to, oftentimes, right? So I like what you said, Dr. Sutherland, about achievable, because oftentimes our clients, when we ask them, what are your goals for treatment? They'll give us this huge, broad, sweeping goal. I'm like, that's great. That's a great goal to have. Now let's break it down. Let's break it down into something that's achievable, something we can work on, and we can help them do that, but we should collaborate in that process. your theoretical foundation is going to guide, it's going to be a thread for you throughout, right? So it's going to guide your case conceptualization. It's going to guide your treatment plan, your goals, your objectives, your interventions. So there should be a clear thread from start to finish. So all of these things are tied together. So like Dr. Bonfini said, if you conceptualize this case through a person-centered lens, well, then your treatment plan, goals, and objectives should align with that, right? So they shouldn't then be CBT or psychodynamic, right? It needs to fit, it needs to be congruent. So goals, objectives, and intervention should be congruent with your conceptualization of the problem, theoretical orientation. So like I mentioned before, if you have a 12-year-old and you assess the problem to be relational between mom and the 12-year-old child, there's trauma there, there's difficulty in the relationship, and it's causing mental health concerns for this child. Well, your treatment plan, then the interventions, your goals should be relational, right? So it all should tie together and be congruent. And this last piece here, the importance of employing a wide lens to conceptualization treatment, right? So we want to be able to be comprehensive and have a just like a bird's eye view of this client. So we want to consider, again, the systems that the client is involved in, the environments, the relational context, right? That is going to help us and guide our treatment process. And then, of course, as Dr. Sutherland mentioned, the importance of your treatment plan being specific, goals being measurable and clear and concise. So I know we have time for questions, so I'm going to hand it back over to you guys. We did a lot of talking to see what questions you guys might have.
Go ahead. Rahana, go ahead.
Hi, everybody. Thank you so much for the question session. I'm a first-year student, so this is my third week in the first class in Cumberland. So I have a lack of knowledge. I haven't taken assessment or diagnosis. So my first question is, when Dr. Bonfini mentioned levels of care, does it include us, the therapist as well, or anything they're doing on top of us, like if they're like receiving other sort of care for their mental health issues?
So what is really meant by levels of care means the type of setting that your client is in. So for example, if they're largely functioning well and they're pursuing outpatient therapy, I mean, most of you probably will be in, when you do your clinical work, especially during the program, you're usually an outpatient or you are in IOP. Sometimes you'll see folks who might be inpatient or might do like sort of a residential, but typically you're working at sort of a lower level of care. And again, you're only in week 3, so I'm sure a lot of the things that we said, you're like, when do I learn that? What class does that come in? Where do we start talking about this? So levels of care is something that is extremely specific, especially for substance use disorders. So when you have that class, you'll talk about that in depth there. But it also pertains to sort of levels of risk in terms of what is the appropriate setting for this particular client. So if I have a high-risk adolescent who has a large history of self-harm and has had several suicide attempts, if I notice that their symptoms are increasing, then I'm not going to just see them in outpatient 1 day a week. That's just not going to happen. I have to up their treatment because it meshes with the risk. So this is something that you will get all of this information as you go through the program. I can imagine this is like drinking water from a fire hose. It's just like, it's a lot. So I would say that, a lot of this will sort of become clearer as you go through the program. Like, for example, we talk about theoretical orientation. You're going to do the theories class, right? You'll do a child and adolescent class. You'll know how it works with kiddos. You'll do a class with, working with addiction. So you'll understand levels of care through that. Process and techniques. You'll learn how these different techniques fold into how you would set up a treatment plan. Dr. Sutherland's diagnosis class is Chef's Kiss Amazing, you will not only learn how to appropriately and properly diagnose, but also do case conceptualizations and treat the client. So all of our courses fit together so that you can do this. Okay. Go ahead, Lauren.
Hi, thank you. I am in Dr. Sutherland's class currently, so I can attest to so far so good. I had a question. I'm at the other end of the site. I start my practicum in January. And so I've taken most of the classes, and this has come up in a couple classes, and I guess I'm just genuinely wondering, I've done theories. Is there somewhere that we can get more specific information on some of the interventions available to non-CBT oriented approaches? There's the push for evidence-based. So then when you go look into the journal articles, you go look, most of what is coming up is CBT. So if you don't identify as a CBT practitioner, or if you're more eclectic, then I find it really difficult to find evidence-based for, let's say you are existential, like you had mentioned. What would an evidence-based intervention for an existential therapist really look like? I guess maybe if there's resources, I would have loved a class with more, I loved my theories class. I really enjoyed it, but even like a secondary theories of modern approaches with some of this really applicable interventions, goals, that you can take some of those other theories and really parse them out into something you can get your hands around.
Yeah. So, and Dr. Sutherland and Dr. Bunch, feel free to jump in. I know Dr. Bunch is our SME for the theories class, so she can probably speak to this as well. So for me, the way that I tend to go about it with a lot of my students, if someone wants to take an integrated approach, that's fine, because they want to make sure they're following evidence-based practices. And a lot of that is sort of the behavioral things like a CBT, like a DBT, because it's measurable. It's measurable in a way that sometimes existential is not. But before we even got on today, I was talking to Drs. Bunch and Sutherland about one of my students from my grief class last semester who used existential to counsel a client. And I was like, okay, let's see how this is going to go. I pull back the treatment plan thinking, I'm going to see CBT again. Here we go. Got my red pen ready. And it was beautiful. It was absolutely beautiful the way that it was set up. It was like they went back into Yalom, they went back into Frankl, and they talked about how to make meaning. How to take, and then took Worden's model, which actually does have an evidence base to it as well, and filtered the treatment plan through that. And it did a beautiful job. Not a single CBT intervention in sight. Like it was a sight to behold. But that takes a lot of effort to do, right? You have to go back to original sources. You have to see the interventions that are underpinning that orientation, and then go into the research to see what pieces are evidence-based. So it can be done, but usually you're going to take a more integrated approach when you're doing that. Dr. Bunch, Sutherland, do you have something to add on that?
Yeah, I think with our program anyway, because it is an 8-week term, you're getting kind of like a preview or a taste of some of these things. So a lot of it is kind of like your own self-research and just kind of more autonomous work. I think all of us have done that as students. So I know, like, I recommend PETSI.com because they have a lot of different trainings, a lot of free ones, and they are very specific. So they're like an hour training that goes over certain theoretical orientations or modalities and how to use them for specific issues. So honestly, I would say a lot of it is research. I have one student in my clinical class right now who is very embedded in existentialism, and actively, like weekly, is just going through articles and reading them and just seeing what's out there. So that's kind of my take. Dr. Bunch may have something.
Yeah, no, just to piggyback on that, Dr. Sutherland, I was going to say something very similar. I think, well, one of the things is, yes, like our program, you get the foundation, right? In order to really specialize and to really get more information, it does take some, additional, right, research on your own. But what you'll find is when you know where you lean, right? So if it's existential and the population that you want to work with, I recommend the same thing that Dr. Sutherland is saying. Find out what evidence-based approaches have theoretical underpinnings in existential theory, right? And see if it aligns with the current population or the population that you tend to work with. So, for example, I come from an attachment-based psychodynamic lens, person-centered. And so the trainings that I've sought out that are evidence-based align with that, right? They have those theoretical underpinnings. For example, emotionally focused therapy has underpinnings in attachment theory and person-centered theory, right? So that fits with me from a theoretical standpoint. And so I've always kind of looked for evidence-based approaches that I can get trained in, certified in, that align. And so, Lauren, you can certainly find some as well. So PESI is a great place for you to look and just find out what's out there. What is evidence-based that has those underpinnings that align with you?
And if I could just take, do you have any issue with insurance companies accepting outside of CBT kind of treatment plans?
You have to know how to write your treatment plan, and you can do it. So like Dr. Bonfini said earlier, you're always going to have to write it in a measurable way. You have to justify what you're doing, justify your approach. But it's all about in how you write your goals and just be very clear in what approach that you're using. So I think to go into it, that would be a whole nother conversation. But as long as you write the treatment plan in the way that you know that you need to for insurance companies, right? And you're justifying everything that you're doing, I have not had a problem.
To piggyback off of Dr. Bunch, anyone who is in my class or who has taken my class, they know how I feel about insurance, and I talk about it every single class, so we will talk about it for sure if that's Lauren who's in my class right now.
Yes.
Jennifer.
Hi, I have a question about comorbidities. Say you have a pretty complex case, say it involves like OCD, and then you have some chronic self-injury and suicidal ideation, but then you also have some social phobia, and you've sort of figured out that there's a good bit of avoidance in there that's kind of maybe the common thread that's connecting a couple things at least. I guess I just struggle with creating a treatment plan for a very complex case that has these comorbidities. Any tips?
So I usually start with the thing that the client most is like, this is what I want to get out of treatment. So oftentimes I will have them sort of prioritize with me. Like, what are we going to approach first? Because sometimes what I want to prioritize and what they want to prioritize are two very different things, right? I'll have a client come in and go, I need to have better relationships. And I'm like, you self-harm constantly. let's try to figure this out. And they're like, well, I think if I had better relationships, I probably wouldn't self-harm as much. I'm like, okay, fair enough. I'm not going to be like, it's my office, I win. No, absolutely not. Like, okay, so that's what we're going to start with. We're going to start with improving relationships. So I would say that's the other collaborative piece, is working with your client. So I got my start in my career doing sort of co-occurring, and typically it was substance use disorders and trauma. And so oftentimes I had to have both in my treatment plan in order for our sort of facility to still be accredited by BDAP and the other accreditors. So I had to start with the SUD. That was standard because that was part of the process. And then from there, the other issues can follow. So it also depends on, does your facility, does your practice have a specific criteria that they're filling? If so, that can often dictate your treatment plan. Dr. Sutherland Bunch, do you guys have?
I agree.
Did the thing. Yeah, sometimes the complex cases, because you might want to treat the OCD in a very different way than the suicide ideation. And that's okay. You can have an integrated approach that, as long as it's written in a way to address those things in a time limited, specific, measurable manner, right?
Okay, thank you.
Farhana, do you have your hand up again?
Yes, I have a question regarding the goal setting. So it has to be measurable, and it has to have an indicator how we are progressing. Do you think if we put indicators, it can trigger client if they're not progressing?
So usually you'll collaborate with your client and agree how many times or what time do they have during the week to realistically work on this. So it's changeable. It is a very flexible number. So If for 3 weeks the client is trying to journal, you know, twice a week and it's not happening, that's fine. We can reassess and move it down to 1, but you need something. You need something to strive towards and progress towards, or else it's just like, okay, week by week we go, and you know, 1 week is 4 times and that's great, but then the next week it's none, and then it's 2. So we need to have some type of guidelines or some type of framework that we're using to know how many times are we trying to do something? Why are we trying to do this? Is twice a week effective or not effective? So we know how we need to change it.
Thank you.
Go ahead, Elena.
Hey everyone. Yeah, so I guess I had kind of the same question. My facility doesn't really take insurance, so we don't really have to work like so specific to those lens, but it's really hard to kind of integrate or kind of think about like, okay, if a client has relational issues and, you know, a lot of anxiety and stuff, how do you integrate those two different, like the CBT and maybe some emotionally focused stuff? Like, how do you integrate that into the same treatment plan, I guess? Like, that was kind of along the lines of my same question, I guess.
So a way that I would do it is I tend to have an integrated approach anyway, and I'm sure most of us do. So, you know, if I'm thinking about something like, what was the first one you said? I know you said anxiety. What was the other one you said? Did you say OCD?
Yeah, just either some really relational stuff
Okay.
or like anxiety, severe anxiety.
Right. So for me, because I'm steeped in DBT, like I would for the emotional or for the relational stuff, I would probably do some interpersonal effectiveness work and interventions along those lines. And then if I was working with maybe anxiety, maybe I would do still probably DBT because I kind of use it for a lot. I would use a lot of the skill set for that, but then I might also fold in some CBT. Right. But other people, if they have a different approach, maybe they're more Gestalt and person-centered, maybe that would look different for people who practice in that way. Go ahead, Dr. Sutherland. I saw you about to mute.
No, I think you said exactly what I was going to say, because the thing about having an integrative approach, it doesn't mean that if you're creating a treatment plan and you have one goal and the objectives of interventions are just CBT, that the second one has to be CBT as well. We switch through all of them a lot, so you can still, you know, have one goal that's CBT, and then the second one, it may be if it's OCD, exposure response prevention, or whatever the case is. With insurance, and you'll learn this more, insurance looks, you fill out certain things and then you say what you're skilled in and the theories that you lean towards. So that's why it's important to have a theoretical framework, and that's why we all say integrative. So that way, when we're creating these treatment plans and when we're doing, you know, our yearly reassessments or whatever the case is, insurance can pull my profile and see, oh, okay, Tiffany has all of these different theories that she is skilled in, so her treatment plans are aligning with that. And we'll get more into that. Dr. Bonfini and Dr. Bunch and I talked about more getting into insurance, but that's why we hound on your treatment needs to have some type of framework when it comes to theory.
I gotcha. And that's why you typically say on those forms, though, like I'm integrative with my approach, and then that they can see kind of pull from different things. Okay.
And depending on the insurer, they might ask you to be specific about ones that you have a certification or training in. So like most of us aren't CBT certified. It's just something that we learned in grad school and throughout our practice. Some people are, like I have friends who are like trauma focused CBT and they have that. But for a lot of us, you know, for me, I started doing DBT before they had like the certification program. And then they did. And I was like, nah, I'm an old lady. I'm not going to do it again. Or like EMDR, you have to have a certification in order to do that. So, you know, you have to put on there like what your approach is. And then if you have any special certifications or any sort of CEUs that are like a testament to the fact that you have expertise in that. So that's something that's important too, that you're staying within what you've told providers or told the insurance companies what you actually do have experience, background, skills, certifications in. You're not supposed to really go out of sketch. Like if someone just said, oh, I'm going to do EMDR and they've never had the training, they're not going to let you do EMDR and pay for it. It's just not going to happen. So
that's what I've kind of been confused about lately is like, so for like, I know CBT people just like research that and then they say that they're kind of skilled in it, I guess, but then exposure response prevention therapy or something along those lines. I think my supervisor said he went through like a information session on it, and he didn't say that you necessarily have to have some specific certification in that, I don't think, but I wasn't sure along those lines if you could just pull from different strategies with, you know, certain methods.
Yeah, I think if you're going to use a specific approach or specific interventions, and you know, it's not one that is so common, that you probably should get some certification and some additional training around it. I think that's a really important thing, just to have for your own self, just so that you know that you're grounded appropriately in what that skill set is.
Thank you.
Right. Is it Chidi? Am I pronouncing
Yes.
that? Okay,
Yes.
great.
So, okay. Yeah, I have a question for Dr. Sutherland. There's a website you mentioned. I wasn't able to get it. Is it Etsy or Petsy? I didn't understand the website.
I put it in the chat. It's Petsy.com.
Okay, you put it in the chat. Okay. All right. Thank you.
Last but not least, Ty.
Hey, I appreciate you taking my question. I thought that comorbidity case scenario was interesting, and you had said potentially like if the client was self-harming, but they wanted to work on relationships. But given the nature of their existing problems and the risk that they pose to themselves and maybe potentially others, would we not want to focus on their main objective while also trying to accomplish an objective and looking out for themselves and maybe their family members? So like, you know, if they wanted to work on a relationship, like relationships, but they are self-harming, would we not want to, I don't know, maybe work on those comorbidities together and focus on the relationship that they have with themselves? So maybe potentially working on reducing the risk to themselves and maybe potentially others through maladaptive practices, while also maintaining current objectives on what they desire.
Well, you're not, so the way that treatment plans are, it's not as if you just work on the one problem and when that's done, you move on to the second. So you're always working on the full plan at the same time. So in a way that, you know, I think when we're collaborating, you really do want to start with where the client is. If we're really trying to be collaborative in nature, right, you're going to start there, unless you're in an agency or organization where you have to start with a certain problem or certain issue because it's how they're accredited. So with my client that I use with the example, the relationship versus the self-harm, I'm working on all of it simultaneously, because if I'm thinking about a client who's becoming dysregulated, they can become dysregulated because of their interactions with others. Maybe there's an interpersonal issue that's going on, and that is leading to the fact that they might engage in self-injurious behavior. So it's part of the same sort of constellation of symptoms. So I'm addressing that all together all at once. So it's not like I'm just focusing here, then focusing there. I'm focusing on the whole plan holistically. We're writing it out in terms of here are the things that we're addressing in terms of our problems and then our goals, objectives, interventions. But we are doing all of the things at the same time, right? So if somebody is working with somebody who has major depressive disorder and a substance use disorder, right? We don't know chicken or egg. Did the one cause the other? You know, is it the other way around, or did something happen that they're coming up at the same time? We don't know, but that doesn't matter, because we're going to work on the symptoms of depression and the issues that are contributing to the depression. And we're going to work on the substance use disorder and the things that are underpinning that as well, right? And part of that's relationships. That impacts both of them. Their own, you know, self-compassion, self-esteem, that part's in there too. Feelings around guilt and shame and all of those things, those are universal across a lot of different conditions, disorders, whatever. So we're going to treat all of that in one fell swoop. We're not going to make it an if-then statement.
Got it. Thank you.
Yeah, no, and thank you for putting that, Dr. Bunch. So for me, because I tend to work with higher risk adolescents, young adult clients, I have a safety plan for every single client that I work with. That is, we do that. I address safety plans and we redo safety plans probably more often than we do treatment plans, because as they develop more skills or other things pop up, we rewrite that. And if you've ever worked with adolescents, sometimes their friend groups can change very quickly. So spending time with this person that used to be like a positive, wonderful support now would not be. And so you have to like take that person off the list and substitute somebody or something else. So yeah, safety planning is a really, really wonderful thing. Well, thank you so much for being here. Thank you so much, Dr. Bunch and Dr. Sutherland, for your expertise and amazingness this Friday.